I think I want to stand here because I don't want to mess with that esteemed panel and get things going. So, and then I can see folks when they come up to ask questions. So you heard these introductions, and I think what we are going to start with is we heard this last session and all of this talk about, you know, the buprenorphine and morphine, and the overarching thing that we're looking at is kind of what happens when it doesn't work, right? You know, you go in and you have all of this stuff that the docs are saying should work, but they don't work. And so I want to start just going down and just, maybe you can just give an overview of your experience with pain management, you know, over the years. What has that been like? And I would say a couple of minutes each, and so that we can get everybody in. So I'll start from the left and just move down.
Before you start, I just want to let you know, Mr. Derek, that we do have one of our guests virtually.
Oh, great. And that's, oh, great. So welcome, Arthur. You had a question?
Yes. The lights are incredibly bright.
Yeah.
It is burning me up. I'm trying not to, like.
It's not just, it's like uncomfortable. That's why it's killing me right now.
So the question was whether or not we can lower the lights. Said the lights are really
so
bright
we have
and
lowered
hot.
the lights, but I can ask the ones that it's tearing up your eyes, come to the side of the table or move over a little bit more so that you can get outside of the light. But unfortunately, if we do not have lights, we cannot see you guys on Zoom. Thank you guys so much.
Okay, great. And thank you for that. And welcome, Arthur. Dr. Henry. There we go. Dr. Henry. I like that. All right, so go ahead.
Hi, hello. My name is Stephanie Starr, and I am about to turn 61 years old next month. And that has nothing to do with me or healthcare. That is all God. Because I was told I would be dead by 20. I had my oldest daughter at 19. They told me to go home, prepare your affairs, figure out who you want to be the main caregiver of your daughter. And yeah, because you won't be here. That was 40 years ago. Thank you. I was diagnosed with AVN when I was 20. I was told I would need to be in a wheelchair at 30. I had my first hip replacement at 58 and was walking around on a shattered one after that, didn't know, had that replaced. My experience with sickle cell care and where I feel that it is really, on top of all the other areas, that it is woefully understudied and under-recognized. I heard a woman earlier talk about in the older population, specifically what women have to go through, but even just older population with debilitation, because I can do 6 standing on my head. This debilitating thing, this is where it's not understood how desperately, at that time, actually before, we need psychiatric help, how desperately being labeled addicted without going through the steps of diagnosing, because let's recognize that addiction is a disease. It has a diagnosis protocol and it has a treatment protocol. So if we're addicted, treat us. Diagnose us and treat us for that and let us get on with the other stuff with sickle cell. Where I am now, I am the unicorn. I'm the only person in my entire hospital, city, that has sickle cell. I have to go an hour away for treatment. So there are not centers everywhere. And I live near San Francisco. I have to go to San Francisco. Those have been the areas where I have been challenged in my care, and there are absolute care gaps. And that's not even talking about the medications and the buprenorphine. That's another story.
Hey, good evening, everyone. My name is Scott Cradoff. I'm a caregiver, been one for about 2 years now, and I kind of gained my baptism by fire, so to speak. I've seen times when when I can, first of all, my warrior is not going into if she's calling me and I'm having to take her to the ED, guaranteed everything that would have been done prior to that has failed. If you then went and taken your breakthrough medicines, whether it's oxy or buprenorphine, and your pain is still spiking at 10, yes, I'm taking you to the ED, and unfortunately, some listen, some don't. And it's been really difficult with the ones that don't, because you almost have to educate them on the fly. But I think a lot more education is going to have to be done, because you can't, it's like you're going to actually sit there and have a person in pain, and anybody who knows anything about SCD knows if there's pain, something is going wrong. Damage is being done to organs or your bones or anything could be happening, and we need somebody to act and not just sit back and say, oh, well.
All right. Disclaimer, I have sickle cell SE, so my experiences may be a little different, but I can say I got great care as a child with sickle cell. I always talk very highly of Dr. Alfreda Blackshear in Tallahassee, Florida. That was my doctor growing up, and she always told me to listen to my body. And I think having those anchors in my head kind of helped me navigate in the adult world in healthcare. Leaving Springfield, Massachusetts, Bay State Hospital, where they knew me on a first name basis as soon as I walked in the emergency room, to go to Georgia, and I'm just sitting there waiting for somebody to talk to me. So I just feel like a lot of the time I had to learn to navigate it on my own journey, on my own terms, and I feel like that's what's pushed me to kind of not depend on medication and think that that's the only solution. I put wellness at the pivotal point for me now. So coming home to my body, I don't have anybody to go home to, but I know myself and my body and listening to what I need. That's something I look forward to. So traveling and meeting people, I love that. But I always make sure I come home to my body and make sure I'm focusing on what I need to really progress and be healthy in the long run. I do want to make sure that everyone understands it's not about too much of getting the pain medication. It's about the recovery. I don't want to be coming out of the hospital in 4 or 5 days still not feeling well because I'm withdrawn off of the pain med. I much rather get right back out there and go with my friends and hang out with my family. So it's about recovery for me, and how long is that recovery period going to take?
No, I'm just going to turn to Dr. Henry online, and then we'll come back here. So,
hello, everyone. I will speak from a different angle because I'm a healthcare provider. And so my experience with making sure that pain is something that is looked at and treated comes from, number one, advocating. And what do I do when my hands are tied as a provider? Number one, I pray. Number two, the next thing is making sure that I'm listening to my patients. As we move on with this panel, I have a story that I can probably share in regards to being that advocate and ensuring that other healthcare professionals in the emergency room listens to our patients. I'll hand the floor back over to the panel. Thank you.
thank you, No.
Hello. Can you hear me?
No,
Okay,
we
good.
can't hear you.
So I'm deaf and hard of hearing, so I can't hear myself. So thank you for that feedback. One of the things that I want to talk about is building on what you said, which is really securing a relationship with the hospital staff. Because they see you so often, you can make friends with these people. and it becomes a family of folks that advocate for you. So really quickly, I was diagnosed with bone infarction at 25 at the peak of my dance career. And so just imagine what that news could do for you. And I do have sickle cell as well, beta thalassemia. And one of the things that made me most nervous was I didn't have an understanding what that would feel like in comparison to the crises that I was used to. So the chronic pain was severe and long and debilitating. Had to tap into services like DOR and IHSS and my family and etc. But the thing that saved me most was the doctors in there not giving up on me. And what that means is they listened to the feedback that I gave them. So if the long-acting morphine stopped working and we were transitioning into buprenorphine, and the buprenorphine at the start wasn't working, they would trust that I could navigate that journey and be able to advocate for myself and then make adjustments along the way. So we could say a little bit more about that, but I think in the heat of our frustration, sometimes that gets in the way of the care that we deserve. So doing the work to work through that is just so important so that you could advocate with intention.
Hey all, so I am 19. I am just transitioning into adult care. So I am from Virginia originally, but I go to the University of Alabama. And in Alabama, there's a large population of people who have sickle cell disease. However, there is not very good sickle cell care. A lot of times, I usually have to go 1 to 3 hours away from campus just to receive care. I had some pretty horrible experiences in the adult world so far. So having, kind of like what Noah said, connections with other people, not just in the hospital that I'm going to, but outside of that, who have sickle cell disease or people that take care of that, well versed in that, is really important, because then I have people that can call down, who can advocate for me. So that's really important. For myself, I'm allergic to morphine. So I have a completely different pain plan than a lot of sickle cell warriors, and Dilaudid being a derivative of morphine, it makes me itch. So it's a way that we have to titrate everything to make sure that it doesn't drive me crazy, and making sure that they give me things like hydroxyzine or Benadryl so that I'm also comfortable while going, as comfortable as I can be, while going through the crisis I'm going through. And a lot of times I'll get doctors saying, you know, you don't need this, you don't need that, you don't need the 50 milligrams of hydroxyzine, or you don't need the 2 milligrams of Dilaudid. And as I've gotten older, I've also learned changing your pain plan is okay. And you need to make sure that your providers are listening to that. And if not, you have to make sure you reach out to your resources to help you advocate for yourself. Because if you are, in the hospital and you start on 2 milligrams of Dilaudid and they give you 0.5, that's not gonna do anything. But that's usually what they'll try to start us on, because they lack empathy, they lack education. And a lot of times it's just the negligence of wanting to start us low on something when you know that that's not what I'm supposed to receive. So it's very important to advocate for yourself, making sure that you have your pain plan in place. And then if they're not listening to that, having your resources to reach out to, connecting with people, not just in the hospital, but outside the hospital, who are well-versed in sickle cell.
Yeah, do you know Dr. Cantor?
Yes, sir.
Okay, sure, because I know she wouldn't like to hear about what's going on in Alabama, so yeah. Mira?
Hi, everyone. My name is Amir Carter. I am the proud wife of Herb Carter, sitting right over there, son Lincoln Carter. Herb and I have been together almost 30 years, so 29 years, and so I've gotten to watch the progression of his disease from 20s, 30s, 40s, and now 50s. One thing I want to piggyback on with you is I'm really big on building relationships with the physicians, with the administrative staff, with the pharmacy. I've made it my business over the years in a genuine way to really get to know them. My concept, or my thinking is, you help me, I help you, we help each other. Herb gets what he needs. So I take that time. We just moved over to a new physician about 2 years ago. I went to the pharmacy just to meet them, so they would know who I am. There might be times where Herb's not picking up his meds, but I am. Herb and I most times sit down before he goes in for an appointment and talk about what are the things that we need to address while we're in the appointment. What are the things that I know what I'm observing at home? Well, what are you feeling? So I go in there with a punch list. I'm very prepared. So that we have a time where we're hitting all the points and making the adjustments where it's needed. But that's what has worked for us over the years, where the building of that relationship over time always benefited her.
Thank you. Hi, everyone. I'm Max. I'm a primary care doctor at UCLA, and I consider myself a good addiction doctor, too. I'm planning to take the addiction boards next year. So my background, I'm from Cameroon, where something like a quarter of the population, or around a quarter of the population, is at least trait positive. So growing up, I had a handful of friends, although they were rare, because as someone else mentioned, in low resource countries, like children with sickle cell often don't live past like age 3. But I remember growing up and knowing how awful a time my good friend's sister was having every time she sought care. So it's something that's been in the back of my mind ever since one, adolescence, but then also during medical training. I am also very afraid of pain. I am terrified of pain. So I think that makes me particularly sensitive to the pain that other people are experiencing. And itching, I think itching is the worst possible thing that you can experience. I actually think it's worse than pain when it's really bad. As a kid, I had, how do you call this? Hydroxychloroquine, and all the medications in that family gave me really bad pruritus, but it's the kind that no Benadryl can fix, or you just have to wait it out because the byproducts deposit under your skin. So I know the misery of itching really badly. So those personal experiences are very much what informs how I approach taking care of people living with sickle cell disease, both in the acute care, like in the hospital, and also in clinic when I'm trying to devise what might be a chronic pain plan, and what might be the acute care plan when we anticipate hospitalization. So for me, when I think, so I like to think about pain like, okay, are we talking about acute pain, or are we talking about chronic pain? They're very different processes physiologically. Acute pain, I mean, I think for all pain in general, multimodal pain is where I like to start. I should, every possible pain receptor, pain involved receptor, should be taken care of to maximize, or rather to minimize the extent to which we have gaps in our attempt at addressing pain. So I know a lot of people will often say, well, I don't think this thing works for me. And usually my response is, it may work in another way. You may not feel the relief you're getting from it, but it may potentially potentiate the effect of the opioids that feel like they work. And it's often hard to tell when you're taking multiple medications which one is the one working, right? But we know that targeting all the receptors is really important. So I beg my patients to just take the Tylenol, right? Just please take the Tylenol. Please take the Toradol. And even if Toradol, maybe it doesn't help your pain, it does reduce inflammation. And the VOE is primarily an inflammatory process, right? And I also try really hard not to limit my options. So for instance, I think someone mentioned having allergy to morphine. I think a lot of times, there's a lot of medical, in the medical chart, right? I learned this when I had to have surgery recently, and in my chart it says that I'm allergic to Dilaudid, but I'm not. Dilaudid makes me itch, but it's not an allergic reaction, and I don't want doctors to think that I shouldn't get Dilaudid. Dilaudid is great. My pain goes away like this, but then I'm miserable from the itching. What I want to be able to do is anticipate that if I gave this medication to this patient, then I need to also know that they're going to be itching. It's not an allergy, and so how do I tackle the pruritus that comes from that, right? So for me personally, and I know there's a big disagreement around this, and I've been in this battle as a trainee, being told by some attendings, absolutely not, do not give IV Benadryl. I've had IV Benadryl, terrified of pain, itching is the worst possible thing. And honestly, it worked in 5 seconds. And I know it's controversial, but I like to anticipate, okay, what are my different tools? If, for instance, Dilaudid is really potent, right? Of a lot of the opioids, it works really fast. Shorter time to onset time and fairly high potency. So I wouldn't want to say, oh, I'm not giving you this person Dilaudid because they're going to itch from it. But instead, I want to think about what are the tools that are available to minimize the side effects of Dilaudid, right? So we have, if I'm at a hospital, like at UCLA, IV Benadryl is forbidden unless you're dealing with a horrible allergic reaction. So there are other options. We have naloxone drips. If a patient is on a Dilaudid PCA, it's fine to have them on a naloxone drip to address the pruritus. We have methyl naltrexone. We have a bunch of options to make sure that we really use all the tools that are available when we're thinking about treating people's pain. This is in the acute setting. In the chronic pain setting, this is...
Max, let me hold you there for a second so we can get to that afterwards. We go to the chronic pain after. I wanted to get to one of the biggest issues for us in the community's emergency room. Trying to understand what's your experience been like. What are some of the strategies you have used to overcome those experiences? And the third thing is, what are some of the changes we think we should make? Because my own view sometimes is that we're trying to fit a round hole in a square peg, right? It's we keep trying to get the ER to be what it's not, And so just what are your thoughts around that, the emergency room experience?
As that mic is coming to the next speaker, I wanted to remind all doctors, doctor to doctor is happening this evening. If you are going, they're waiting for you in the lobby. And Mr. Robeson, we also have questions online, so we'll move our moderator up so that you can see her as well.
Okay, great, thank you.
My experiences in the emergency room have been difficult in my older years, like where I am now. Originally difficult. I had to be vouched for by a nurse from Cedars who moved up to Santa Rosa because by the third time I went to the ED, they thought I was drug seeking. Since then, I have other doctors up there who I go on their shifts because I know when they work. And I know when I'm going to have to go in ahead of time. I wait until I know they're going to be there, and then I go. And then we don't have problems getting what I need. What I wish would happen that would be made available in the ED and all over, because we know that opioids usage in America is not the same as it was. We're not going to be able to get the quantity of medications that we are used to having. What I want to see is insurance companies and emergency rooms and all points of care stepping up and providing acupuncture, acupressure, all of those support resources in the area where we are seeking care. You can do that in the emergency room. They do it for the staff. If they can do it for the staff, they can do it for us. Those are the kinds of things I would like to see for a change, because I agree, we are trying to fit a round peg in a square hole, and we're trying to look at this as if things will remain the same and we're going to have constant access to these medications. We are not. We're not going to have that access. So to me, the question is not, how do I continue to get the same drugs, although that is very important. But for me, it is now as an advocate and for others and for myself to talk to those people in those key places to get them to understand we do everything, because I don't get the feeling from when I'm the unicorn in a facility, the burden for me to have to educate before people can treat me is probably my biggest one. So if people really understood the degree to which, no, we're not just sitting at home popping pills. We really are doing all the work. We're researching, we're doing the sound and vibration therapies. We're doing all of that. Make that available alongside of, not just buprenorphine, which, okay, but alongside of it. Why are we still talking about a drug when there are other things that are available? And for me, that's what I want to get across. We need to kind of change our thinking. Yes, the drugs work, but what happens when they're not available at all?
And does anybody have anything else to add? And I think just in the interest of time, we won't all be able to answer all the questions. So if you want to add something that's been added, let's do that. And then I think, no, we're going to, not for no, because we still have time, but we're going to come down and then we're going to go online because I see Elle there waiting. So let's go ahead and hear these responses and then I'll get to Elle.
Okay, I just want to, okay, can you hear me? Okay. One of the things I would like to kind of add to that, when we're taking our warrior to the ED, a lot of times they actually have like pain management plans that are on record, but for some reason the ED does not want to go by the management plan. They want to do something totally different. And I just think that there needs to be due diligence for people reading the charts, because you'd be amazed at how many times I can take a person to the ED and the attending physician will not read the charts. They're going off of assumptions.
So my experience with the ERs is interesting. Up north, and that's why I was raised in Springfield, Massachusetts, I had great ER experiences. From me arriving to the hospital, from the nurses being right there, ready to go, they already know what I need. It was amazing. But when I moved to Georgia, totally different experience, and having to go through 4 different hospitals, I've learned that it's not about the hospitals or the doctors anymore. It's more about the hospital culture that I look at as a whole. All hospitals are different, we know that, but when there's a hospital that really thinks about the patient, all of the patients, and not just certain ones, you see the happiness in the building. You see the camaraderie from all the nurses and the doctors. You see that they actually care. And I have been blessed to be with another great doctor. My hematologist is Fad El Rossi. Yep, that's my boy. I love that he just thinks outside the box, and he understands that my sickle cell is different. And I don't think other ACPs put in the work to actually try to get to know their patient and understand what they need specifically for that individual, instead of putting us all on the same playing field.
Dr. Henry, and then we'll come to Noah.
Yes, I think what we are hearing here
You're
is
on
the
mute,
same
Dr.
thing.
Henry.
Can you hear me now? Can you hear me?
Yes.
I think we're hearing the same narrative, and I'm going to put a term around this narrative, and it's implicit bias, right? So going into the emergency room, I am by trade a hospitalist, a nurse practitioner, primary care nurse practitioner, and also sickle cell from an adult care standpoint. a few years back. So when we're talking about going into the emergency room, I spoke earlier about making sure that there is room for number one, prayer, number two, advocacy. But what we have to do is listen to our patients. Everyone that I've heard so far has made the claim of we are all individualized. We are all very different. So it's important to have some individualized pain management plans on the patient's chart, right? To the point of the gentleman on the panel, he mentioned we can have those plans, but they're not being utilized. So what do we do as healthcare providers to enforce this, to ensure that our patients are getting what they need, and to demyth the implicit bias that we see? It's important to have champions in the emergency rooms or emergency departments, someone who understands what sickle cell disease is, what sickle cell disease is not, and then make sure that our patient populations are getting what they need. Also, when we talk about healthcare, we are sometimes as providers as good as our last preceptor or our last attending physician or the last person who taught us. And so the emotions that they have about a disease process, we can sometimes take that on if we don't have the wherewithal to say, hey, let's stop for a moment. Let's talk about culture, as what was mentioned before, and be able to change the narrative as a whole. So making sure that we are implementing those pain plans, making sure that we understand that one size does not fit all when we're treating pain for sickle cell disease, and ensuring that patients are getting what they need. I will say for myself, I am one provider who I know about the controversy about using IV Benadryl for itching. I am one who don't mind using it. I understand how horrible the itching can be because I've seen it firsthand, and I listen to my patients. There are alternatives as well. Sometimes you can give Benadryl IM to help with that. And so the narrative is listening, making sure that we're listening and implementing those plans of care, but also doing it with some empathy and some compassion, and knowing that this is a disease process that no one asked to have. It causes pain. So what can we do to ensure that it's better?
Thank you. Yeah, please, briefly. Yep.
I also wanted to say, even though it's a plan, we also want to make sure that there's a strategy as well, because I do think that the medication is needed, but when we need it to work. So how do we kind of like minimize using so much? That way we can actually utilize it when we need it. Because I felt like when I had the medication, I was on Percocet 10? I felt like that was entirely too much medication for myself. But I'm used to going on 1 milligram of Dilaudid when I go to the hospital. I have a low dosage of Percocets at home, but it's there because I know when I really need it, it's gonna work and I don't have to have such a high dosage. So I just wanna make that clear. There also has to be a strategy to make sure that this patient can kind of wing off of these medications and not feel like it's a dependency.
No, we're gonna come.
I'm sorry.
Yeah.
I was about to say it's
Wait, yeah, this one. Thank you. I just want to say also, like what Corey was saying, my pain is very different. I also have sickle cell SC. So a lot of times they'll assume that it's not as severe. When I say I start on 2 milligrams of Dilaudid, that's what I mean. When I say I need this for itching, that's what I mean. When I say I need this amount of heat, that's what I mean. My doctor, like I said, changed my pain plan. So we decided to start with a lower dose of Dilaudid so that I'm not itching so much, because the itching can be bad. I mean, for me, it's like unbearable. Yeah, it's like the worst ever. And I so uncomfortable. And I feel like I focus even more on the itching, that I'm so stressed out, my pain isn't even going down because I'm not relaxed enough to think about, having my pain go down. I just feel so stressed out. So we decided to do a lower dose of Dilaudid with ketamine. Ketamine is a very strong drug. A lot of times, I'll go into the ER or whatever, and they'll say, oh, you take this amount of Dilaudid and this ketamine, that's going to make you really loopy. Well, yes, but that's what I need. That's the pain plan that we created for me that would work so that it actually goes down. I'm also a dancer and I train quite often. So my chronic pain and then the way that my crises come into fruition is a lot different than a lot of other warriors. So that's why, you need certain medications, a certain cocktail to work for whoever the warrior is. And so sometimes in the ER it can be just really difficult to get them to hear me, especially because they can be stronger medications. However, like I said, having your resources, I know that my nurses back home put this in the chart. You can pull it up. I have a medical alert card. I really do advise everyone to get on. All you do is put all your medication and it's free, your plans and stuff like that. You can scan the QR code and they can see your plan from there. So you don't have to explain so much. Because like she was saying, I don't feel like I need to work when I go to the ER. I don't feel like I should be working when I go to the hospital. Like I shouldn't have to explain to y'all over and over again. Just pull it up. It's right there. So I think that's, for me, what's worked best, going to the ER and having trouble with people listening to what I need to feel better.
Oh, well, you guys kind of said it, but we're from Washington State. We moved to California in 2001. And in all honesty, Herb was treated at the University of Washington, where his physician was, and he had a fantastic relationship with ER, so we never had any issues at that ER. I do think also, again, building of the relationships, I took time to go meet with people so they knew who I was, Herb, all those things. But one thing when we moved to California that his physician did for us, and mind you, this is 20 years ago, is he, on his letterhead, the University of Washington put together a protocol. And I had that on my person. So when we came here to LA, or to LA where we live, Herb had a sickle cell crisis and I had it on me. So when I went to the hospital, I was like, this is how he's to be treated. And if they had questions, I'm like, and you can call this physician. And it worked. And I have it with, yes, we have, my chart and all those things now, but I had it on me, like, here, this is what we do, this is what works. So that's just an additional step. His physician now, who is fantastic, was like, I never really thought of that. Because what if you're traveling or something like that? Right? You need it with you. So that would just be something to maybe think about, that you can put together with your doctor so you can have it in the event that you have a crisis, and perhaps it may help some when you're in ER.
Max, you had something to add?
Yeah, I wanted to be able to, so I think in the ER in particular, these are, folks who, they don't see people with sickle cell disease all the time. And I think the issues are twofold from my vantage point. There's a nurse, sort of like a nursing component, and then like the physician decision-making component. And both of those, when someone is experiencing either like underdosing of their medication or usually underdosing, that's a big one, despite what an acute care plan says. I think that often, and perhaps more often than not, comes from like true fear of doing harm, because oftentimes people are like, oh my God, I've never given 8 milligrams of IV Dilaudid before. But it's like, well, this patient's acute care plan says so. But that sort of cognitive bias that people have, like the fear of what might happen on the other side of administering a relatively high dose that they're probably not very used to, is a big one to overcome. And usually, I mean, different people have different strategies, but like, the people who are thoughtful can go through the patient's chart and see that someone has tolerated those doses before, and that is assuaging. But I personally, and this is a luxury because I only do direct like primary care, or direct clinical medicine like once a week, but I try whenever one of my patients arrives to the ED, like at the ED at UCLA, if I am not busy, I'll go to the ED and like say hi to the team and be like, hey, I'm this patient's PCP. Let me know if you have any questions, if you need anything. Their acute care plan is already in there. They really appreciate that, because the word from another colleague a lot of time really does help, like help assuage those sort of like concerns about harm. The other piece is, unfortunately, we are in a system where efficiency drives everything, right? But like pain care cannot be efficient. You have to check on the symptoms, administer the Dilaudid, come back 30 minutes or 20 minutes later, check again on the patient, administer more if you need to, or ask for the doctor to order more, right? Like, so if a nurse usually has 3 patients for whom they enter the patient's room like every 2 hours, like that doesn't work with sickle cell disease, right? And you don't end up, like nurses are not given like ICU level assignment when they have a patient with sickle cell disease. And that's how delays in medication administration happen. And so for me, I often offer my patients, how about we put a PCA as an option for your pain, because that's an easy way to get around the delays in care. Because it's also true that, yes, there are racist nurses who will drag their feet when it's time to come give you medication, right? Like the PCA gets around all of that, you know, assuming that the doctors are gonna order it and that they have PCAs in the emergency department, which is also another sort of element of lack of resources or like, you know, efficiency-driven care. But I think in general, leveraging whatever technologies we have, and also if you do have a provider that happens to not be super busy or who is known in the system, making sure that they, you know, take the time to reach out to your team when you're going to be hospitalized, because I think it can go a long way.
Thank you. And I think I've been neglecting the online folks, I apologize. And so they have some really excellent questions online or comments. So Elle, did you want to give us a few of those?
Sure. So this has been terrific so far, and I'm going to give one question right now, and that's looking forward. What kind of research, advocacy, or innovation would you like to see so that warriors are not left without options when medications fall short?
No, you want to start? You didn't go. You didn't speak the last round, so you want to start us off with that? Elle, could you repeat that for me one more time? Because it was a pretty detailed question.
Looking forward, what kind of research, advocacy, or innovation would you like to see so that warriors are not left without options when medications fall short?
For me, the best way to simplify that is just support from our family, support from the staff, and again, support in the room. I know it's hard when you go state to state, but for the most part, even if you're somewhere where you're not familiar, having someone you can call and or someone on the phone who can be another voice to support you in that space, I think innovative ways to do that moving forward will save lives.
Yeah, so I'm developing a research portfolio, and some of it is focused on sickle cell, so I love this question. I think there is a dearth of evidence around leveraging behavioral approaches. So for instance, there's something called pain reprocessing therapy, which is extremely effective at reducing pain among people who are experiencing chronic pain. The 5-year follow-up study just came out in July. We're not using that, right? Ami Patel, Ami and I work together. We talk like almost every day. Ami and I have talked about the idea of like potentially leveraging things like one-time cognitive behavioral therapy, because there is some evidence out there that even the one-time intervention around CBT can be pretty effective at helping people like navigate their pain, and you see a reduction in pain scores. I also want more research done around like really maximizing mental health care, because your emotional state significantly influences how you experience pain. Like there's a sort of like objective physiological stimuli from pain, but then depending on your emotional state, your various opioid receptors behave differently. And people might know about this. There's the the suzetrigine was like one of the so this is the latest FDA-approved medication for acute pain, and the first one in like decades or something, I can't remember. But it's a peripheral only agent, so it works on your sodium channel receptors and doesn't affect the brain. What I'm really hoping, unfortunately, it's not very potent. When in the randomized control trial used to approve suzetrigine, it was compared to Vicodin essentially, right? But I'm really hoping that because now we have one medication in that class that is FDA approved, that really facilitates more research for other sodium channel blockers that can be really effective and not have the neurological side effects like that we often worry about when we are cautious with administering opioids.
One thing that I think to answer the question that we need the ER staff to change the way they look at the word guidelines. They are not, guidelines from our perspective mean individual to the person, not, oh, it's an option not to follow them. And that is the biggest thing we can do, is make it so that whatever guidelines we have for us in our chart, because they're there, we've got them. The issue is they will not follow them. My poor doctor, my doctor is Avi Ramchandani. He does not need to get a call from the ED because there's a doctor who doesn't want to do it. It's in the chart. He's got stuff to do. Follow the chart. And the second thing, that drug does work because I'm taking it. So it does work.
I was just going to quickly say, like other therapies, like Elle mentioned, when medications don't work, there's something called therapeutic apheresis through the American Red Cross. I know is a main organization that offers that, but I know that helps a lot of warriors. And then also other therapies outside of Western medicine, massage therapy is a really big one. Acupuncture, that's something I've been getting since a very early age, so that now I'm feeling like it really has helped me emerge into adulthood and transition a little bit better. And then also kind of like piggybacking off, mental health is extremely important, and that mindset that you have can really contribute to how severe your pain can be. I started therapy at very, very young because I didn't know how to cope with my illness. My mom could literally time the amount of when I would scream, when I would just be in pain. It was like every 8 minutes or something like that. That's when I would just scream because I didn't know how else to cope. I didn't know how to deal with it. So having, access to mental health resources has been such a blessing from such an early age to make sure my mental health has always stayed intact. And then as I've gotten older, the upkeep of that, I know a lot of us feel like we don't need to, or you don't feel like that's something that needs to be, a part of your regular routine, but it absolutely does. Having that is, I think, one of the most important things. And then the last thing I was just going to say was having things like you do in the pediatric hospital can transition over into adult care. Why can't adults have access to music therapy? Why can't adults have access to, animal therapy? Why can't we have colorful rooms? They don't just have to be gray. They don't have to look like jail cells just because we're adults. Like, we can have access to colors. We can have, things like Legos or things like that I think really elevate the experience for me when I can just sit with my hands and do something with my hands, do Legos or make bracelets or whatever, that sort of thing, especially because I am a dancer, and when I'm not able to get up and move, it really can be depressing. So having access to other resources in the adult world specifically is extremely important, something we should implement.
Yeah, and Scott, I'm going to get you to do the next one, the next question. Wait, so I want to have you answer the next question because I want to get, but just along those lines, Diana, funny story, my son is now 26. When he was much younger, the thing he liked best about it, he didn't like going to the hospital, obviously, but was a child life specialist. And in talking to an adult nurse once, she said what you just said. She said, every adult hospital needs an adult life specialist. Why don't we have an adult life specialist? But Elle, can you give us another question?
Certainly. So the next question is, have you ever experienced fear or frustration when standard treatments failed? How did you manage emotionally and practically during those times?
Go ahead, Scott. You want to take a shot?
Well, from a caregiver's
Scott,
perspective,
hang on one second. Let me do a housekeeping thing. When do we wrap up? Do we wrap up at 4:45 or at 5?
We wrap up at 4:45 because we have the celebration of life.
Okay, so my clock right here was saying 19 minutes. So
Yes, that's 19 minutes into the celebration of life.
oh, so 10 minutes. Okay.
I think Dr. Rayleigh is giving you 10.
Thank you, Dr. Rowley. So with that in mind, you have like 1 minute, and then we'll get to another question.
as a caregiver, it is very frustrating when you kind of feel like your warrior has hit a wall where she cannot get past the care she needs. But one of the things that, in my experience, you have some petitioners that will say no, and that's the time when maybe you need to engage another practitioner that'll say yes.
And Elle, why don't we go from online to online? So, because I know Dr. Henry has been quiet for a little bit. So you have another question, and Dr. Henry, could you take it?
Sure. So, Dr. Henry, we'll start this question with you. We've heard a lot from the panelists about trust and the importance of trust with their providers. From your perspective as a provider, how can warriors build trust? What are some steps they can take to make it a more trustworthy environment?
That's a phenomenal question. I think I want to start this off with not necessarily what warriors can do to build trust, but really what can providers do to help build that trust, right? So number one, I think we can say, listen to our patients. Make sure that our visits, and I'm speaking from an outpatient standpoint, not necessarily inpatient in the hospital, but starting there, making sure that our visits are not 10-minute visits and our patients feel like just a number, feel like it's just a box that's being checked. Get to know who your patient is, what they like, what they don't like. And for me personally, when we talk about coming to clinic to get lab work done, I don't just draw labs and then say, oh, okay, well, I'll see you in a month. I am printing those labs off. I am sitting down with my patient. I am teaching them what it is I'm looking for and explaining it in layman terms. That builds trust. I am advocating in a sense to let them know that I hear you. So let's partner in this, okay? It's not me as your provider telling you what you're going to do or what I think is best for you to do, but it's us collaborating as a team to make sure that we do what's best. And even if that includes incorporating caregivers into the care. And then really talking about a multidisciplinary approach to care, which is so important. We can't just have sickle cell providers or hematologists, running the fort for this. We have to make sure that everyone is involved. I've heard someone talk about social workers. I've heard child life specialists, and the adult life specialist is phenomenal. Pharmacy, all different aspects. Cardiologists, we need providers for every organ of the body to be involved. And we need to make sure that our patient population understands their care and we're open with them with their care and we're honest with them about their care. Then they begin to open up. Also incorporating mental health strategies. One of the panelists spoke about CBT, which is cognitive behavior therapy, and what that looks like. Pouring into patients knowing, hey, you can journal some things and we can sit down and talk about it. Once those living with sickle cell understand that you truly care and they feel the compassion and the empathy, they know who they can trust. And they know that their particular provider will advocate for them and build other providers to do the same. So building those champions after that. So it's a work in progress. But honestly, it's twofold, and it starts with the provider.
Thank you, Dr. Henry. I'm going to have Amira. You've talked about relationships, and just in 1 minute, if you can tell how you built that. And while she's speaking, in the time we have left, if each of the panelists including you, Dr. Henry, can just begin to think about what one last message do you want to leave the audience about just the experience with pain management, what you want to see differently, anything that's on your heart to just leave with them. And my challenge is one breath, right? We're going to do that in one breath. So we'll hear from Amira, and then each of you, I'll start with you, Stephanie, and then we will do that. But Amira first.
So, when you asked me about building relationships, I had to think about my mom. And my mom's an English teacher. She was an English teacher. And one thing she would always talk about is your tone, how you speak to somebody. And so when I think about how I've built relationships over the course of almost 30 years advocating for Herb, I think about how I came into the room. I was prepared. I had questions. And I was young. I was 19 years old when Herb and I got together. But how I expressed myself it's key. If you approach someone and you're angry, that is what you're gonna get back, right? That's just a natural human response. And so that's something I've always worked on. I've had many situations. One, Herb and I were just talking about a few minutes ago about a pharmacist. She didn't know me. The head pharmacist was gone for the day. Herb was being treated, and I needed to go pick up his medication. There was an issue with the insurance, and I always remember, I'm just one of many, many, many patients, right? So I understand that you see a lot of people, but what I did was, I was kindly firm. If I don't receive this medication, this is what's going to happen. Eye contact. I think it's like, how do we build relationships with people really starts with how we communicate, our tone, how we walk into a room. So I really worked on that over the years, and I was successful with it. And I didn't always encounter people who wanted to help us, but if I needed to go step away and pray for a minute, because I do believe in prayer, that's what I did. If I needed to ask, it doesn't seem like you really want to be here today. Doesn't seem like you really want to help Herb. Can I have someone else? You have the power to ask for someone else if they're not giving you what you need. So that's some of the strategies that I've used over the years that have really, really aided in us having a village of people who now call us. That's what I want. They call us. How are you doing? Because I took the time. So that's some of the things I did.
Thank you. Your parting message, Ms. Stephanie, and we'll just go down the line. One breath.
The two things I would say is, number one, we all need to go home and start talking to our emergency rooms and providers. We need the other stuff. We need the acupuncture. We need that stuff. And we ourselves, the second part of that, is we ourselves, if we're not using those, need to avail ourselves of every possible non-medical thing under the sun to use, including therapy. And I don't understand why people who are born with an illness that will last them their whole lives have to fight for therapy when there are other illnesses that they get diagnosed as an adult and they're practically pushed into therapy. We need to really get every possible thing we can get and ask for it and utilize it ourselves. We have to let them know it works. We are the research bodies. Let's talk about it.
One breath.
Okay, in one breath, I want to see some of the hospital chains, for lack of a better term. They could spend money on everything else. You could take a little bit of that money and train some of your staff in what sickle cell disease is, so that when we take our warriors or they have to go to the hospital, it's not just blank stares wondering what to do.
Something I would want to see in the future is increasing number of centers of excellence for sickle cell warriors. I know at Grady Hospital, have a good sickle cell comprehensive center, and they follow those guidelines, individual guidelines. They take you in and they pretty much treat you the way you want to be treated. And I don't see that in a lot of other hospitals. I know it's not always feasible because of funding, but I do think it is something that we could try to work towards, because I know some hospitals may have like a whole separate building for a cancer. Well, if that's the case, we could get a little room or a little, something downstairs of the cancer building for sickle cell or something like that, where at least we feel heard, we feel seen, and we're not being pushed under the radar like it's just a general situation. No, this is something that's very imperative. I need you to help me. But if I'm, kind of separated from everyone else, it does make a difference.
Gratitude. Transitions are hard, and along the journey, you have resources, you have community, you have CBOs in your local area. I'm blessed to be able to be a part of SCAASF and also Cayenne Wellness Center. So those things have been life-saving for me. Stay connected, keep the gratitude, keep going through the transitions.
Sickle cell has been around for over a century. We've evolved a lot. However, there's a large incongruity in how we're treated versus lots of oncology patients. Continue to hear us, continue to listen to us, and listen to our stories, and making sure you know that everybody is different, everyone's an individual. By textbook, it might say that my sickle cell is not as severe just because it's SC, but you don't know how it is or what it is that I go through unless you're in my body, which nobody understands it but me. So listen to your warriors.
I've already spoken, so I'm good. Did you have anything to say?
Yeah.
One breath.
Does this work? Actually,
Yes,
yes. Acknowledging how much bias there is in the system and how much resource allocation limit the quality and kind of care that people can receive. I think at a human level, I do want, I want us to think about the fact that a lot of the conflict, like all of those things put aside, a lot of conflict that providers and patients sort of encounter where we butt heads come from how much we agonize and struggle with uncertainty and like risk management and really the fear of causing harm when we are often in uncharted territory, right? This is a relatively rare illness. Most people have like never taken the time or like had the chance to navigate this. So it's a limitation of just human nature, how much uncertainty also causes agony on the provider side. And I think that mutual understanding of that distress could potentially alleviate conflict or like make getting over the conflict easier.
And Dr. Henry?
Yes, this is to all the warriors in the room. I want you to know that you are valued, you are seen, and you are heard. And there are educational tools that are actually taking place to help build out education and champions in sickle cell disease. So your care is taken seriously in all of these healthcare sectors. So thank you.
Okay, so we heard, let's see if I can do it in one breath, right? We want to make sure we have more centers of excellence, non-medical treatments, more dollars on training, gratitude, and resources, making sure we're hearing us and people are listening, build relationships, ask for more caring, and to release conflict, understanding the differences to avoid conflict, and that to close it out, sickle cell warriors are valued and there's training. Thank you guys very much. Went over a little bit of time, but I think this was an awesome panel. Please give the panel a big round of applause. And I will turn it over to Dr. Rowley. Thank you, Dr. Rowley, for having me.